طيب السلام عليكم ورحمة الله تعالى وبركاته، والصلاة والسلام على أشرف المرسلين. أتمنى للجميع التوفيق. ومعلش هي محاضرة في بعد محاضرات دسمة، فأتمنى يستفيد منها الجميع والجميع موفقين إن شاء الله. طيب my topic today is congenital and acquired hemolytic anemia. I will start with the content is red blood cell biology and hemolytic anemia definition. Then we'll go to approach to diagnosis. And then we'll talk about macro and glucosic hemolytic anemias and congenital hemolytic anemia, which is membranous and enzyme deficiency and hemoglobin abnormality. Then we will go to acquired hemolytic anemia, which is immune and non-immune. So I will start quickly with the red cell biology, quick refreshment. We talk about red cell structure, which is biconcave, cellular, and have a cell membrane. And it is a flexible fluid cytoskeleton, and she have vertical connection and also horizontal connection. And on both this connection, vertical and horizontal, we have the congenital abnormality of hemolytic anemias. And then we will talk about red cell biology, which we will talk about the RBC, red blood cell membrane, which is made in the bone marrow, mainly also in spleen, mainly bone marrow and in spleen and liver also. The normal red blood cell lifespan is 120 days, and all the cell typically removed by spleen. We have approximately 1 to 2 of the red cell are lost and replaced daily. Red cell function is to deliver oxygen and energy to the tissue. And oxygen, we know that it's released by 2 and 3 BBG, and also oxygen saturation curve, which is controlled by pH 2-3 DBG and temperature. Then we'll talk about the red cell biology. Also, we'll continue. We'll talk about erythrocytosis. The erythrocytosis means production of red blood cells, which is regulated by erythropoietin, which is a hormone made by kidney. And this erythropoietin hormone increase by with hypoxia. If there is a hypoxia in any place in the area of production, then we will the body will release red blood cell, and you can see this red blood cell in peripheral blood, which is called the reticulocytes. And usually it needs a supravital stain to be seen in peripheral blood smear. Then we will talk about the hemolytic anemia definition. It is early destruction or rupture of the red cells. We have 2 types of broken. We have one called extrinsic and the other called intrinsic factors. Extrinsic factors like micro and glucosic hemolytic anemias, which there is a shearing in small vessels from fibrin and platelet microthrombi, and also antibodies from extravascular hemolysis. And also we have mechanical, which also there is shearing like heart valve or MASH hemoglobinuria. Also medication can cause extrinsic hemolysis. Then we will go quickly to intrinsic factors, which are like cell membrane abnormalities or unstable hemoglobin, as we mentioned in previous lectures, like sickle cell anemia and thalassemias. And also we have oxidative damage enzyme abnormality, which is inability to produce from oxidative stress. So this intrinsic and intrinsic factor in detail, and we can understand this later in these lectures. Then we will talk about hemolytic anemia, the clinical features, which the patient can present with a fatigue, respiratory distress, tachycardia, sometimes cardiac failures if it is advanced, or severe hemolysis, and pallor, jaundice, dark urine if intravascular hemolysis, and hepatosplenomegaly. This is general clinical appearance. Sometimes around, not sometimes about there is a risk for all chronic hemolytic anemias to have a risk factor for a blastic crisis. Usually a blastic crisis in hemolytic anemia like sickle cell anemia or thalassemia or any other hemolytic anemias, if there is a viral suppression, can cause this hemolysis, like parvovirus B19, which is a common cause of a blastic crisis in hemolytic anemias. And what happened in this viral suppression? Usually there is a sedation in erythrocytosis for 7-10 days. So the patient will have profound reticulocytopenia, which will lead to profound anemia. So usually this patient, they need a time to recover from this reticulocytopenia or from the bone marrow suppression. And sometimes if the profound anemia, they need back RBC transfusion as a simple treatment or simple transfusion. Usually it's solved with just after single transfusion. It will not stay as a chronic, just super added to hemolytic anemia. What to do if we have a patient with hemolytic anemia? The workup first will see the evidence of increased red cell production. Usually we'll see CBC, we see hemoglobin, and we look for hematocrit, and we look for RDW and for reticulocytes. Usually we'll see low hemoglobin and high retics, and MCB will be high, and hematocrit will be low. Then we will look for the evidence of red cell destruction. Usually RBC morphology, we can see microangiopathic or we can see schistocyte in the smear and also spherocytes. Then we can look for the total bilirubin and direct, usually unconjugated hyperbilirubinemia. Then we will do urine analysis. We can see hemoglobin in urine, which is called hemoglobinuria. And also we'll look for hepatic bilirubin, which usually is low. Plasma-free hemoglobin, and also we look for LDH, which usually is high. Hemolytic anemia, lactate dehydrogenase. It is not specific for hemolytic anemia or RBCs. It released from many tissues when damaged in our body, but also it increases RBC destruction as in hemolytic anemia. Hemoglobin, oxidative stress or tissue damage. We see free hemoglobin can cause oxidative or oxidation or oxidative damage. Or also you can see which is low hepatic bilirubin also in the blood. Bind plasma-free hemoglobin or inhibit oxidation. So in conclusion for this hemoglobins, we will see low hepatic bilirubin or free hemoglobin in urine. Okay, then we look for hemolytic anemia in summary of biomarkers used to determine hemolysis. We have high LDH, which we have low hepatic bilirubin, we have increased unconjugated bilirubin, and we have high reticulocyte or increased reticulocytes. Also, I will add, we need to reticulocytes. It can be with the CBC differential, but also we can look in blood smear for reticulocytes, spherocytes, schistocytes, spherocytes, all can be seen in blood smear in addition to this. Okay, the most important how to approach a patient come to us with a hemolytic anemia. Usually, if there is a hemolysis, it can be microangiopathic hemolysis or non-microangiopathic hemolytic anemia. Microangiopathic hemolysis, congenital or acquired. Non-microangiopathic hemolytic anemia, it is intrinsic or extrinsic, as we mentioned, congenital, acquired, or it can be, as we mentioned, congenital and also acquired, both sides, intrinsic and extrinsic. Okay, our approach to microangiopathic hemolytic anemia, which is caused by shearing of red cell in small vasculatures. They are broken apart from microthrombi, fibrin, strength, and platelets. And we see evidence of schistocyte on smear. If this microangiopathic hemolysis, or we call MAHA. Usually we will look for blood smear and we'll see schistocyte, which like tear RBCs, as we see in this blood vessels. You see like schistocyte. If you see these three pieces, the red, and also the triangle, the red, fibrin, and also this is the red cell when it is broken in the blood vessels, and under the microscope we choose schistocyte. Intravascular hemolysis, red blood cells are hemolyzed inside of the blood vessels. Extravascular hemolysis, red cells are hemolyzed through destruction by macrophage as they go through spleen or liver. So in intravascular hemolysis, there is a RBC hemolysis inside the blood vessels. Extravascular hemolysis, RBCs is hemolyzed or destruct by macrophage in liver or spleen. As we mentioned, RBC is a product in pulmonary mainly and in liver and spleen also. So when extravascular hemolysis, destruction in just two sides, liver and spleen. When intravascular hemolysis, it will be in the red blood cell itself. Then we will go to, still we'll continue with the micro and basic hemolytic anemias. This what called thrombotic thrombocytopenic purpura or called TTP. And also there is what called hemolytic uremic syndrome, HUS, and atypical HUS. There is also secondary MAHA, autoimmune vasculitis, or it can be by drug induced or by stimulating intravascular coagulopathy, which is DIC. So we'll talk in details about TTV and HUS and atypical HUS and also about secondary. This shows to side under microscope. Okay, we'll go to TTB, which is called thrombotic thrombocytopenic purpura. Usually there is a classical Bentad definition for TTB. Usually patients have prolonged fever, mental status change, and renal insufficiency and thrombocytopenia, and micro and basic hemolytic anemia, what called MAHA. So if you have these five clinical criteria, then we can say this patient have TTB. And usually, sometimes they cannot come with exam, can come with fever or can come with picture near to hemolytic anemia syndrome. And usually, this patient very difficult to, not easy to diagnose, easy from presentation in ER. They need to look for the history carefully and for the clinical presentation and the lab. Okay, the pathophysiology of this is a decreased activity of ADAM13 enzymes, ADAM13 cleavage membrane factors, and this usually there is a decrease of the activity of this ADAM13 to ultra high molecular weight in membrane, which is this side, which when there is a deficiency cannot the ultramolecular weight membrane cannot be cleaved, and this lead to platelet aggregation in the endothelium, lead to shearing of RBCs. So at this point, then suicide developed, and we will see platelet aggregation, which lead to TTB. TTB diagnosed by measuring ADAM13 activity and detection of ultra high molecular weight membrane factor. Usually need specific lab to do this ADAM13. ADAM13 can be congenital, sometimes can be acquired, but the most common is a congenital mutation in ADAM13. And usually this patient require plasma infusion regular, and this patient not need a platelet. Platelet is contraindication, and usually harmful if you give a platelet for patient with TTB. As you mentioned, there is a platelet aggregation, which can lead to thrombosis and we harm a patient. So we need to give a plasma infusion, not a platelet transfusion for patient with TTB. And usually they respond to plasma infusion, and they need regular plasma infusion or FFB regularly, and like long life treatment. Acquired, just if there is acquired, we need to give steroids, and also we need to do a plasmapheresis. Sometimes they give rituximab. So secondary, the treatment is by different modalities, but acquired usually we need to replace the plasma itself. This about the TTB. Then we can go to hemolytic uremic syndrome, usually following bloody diarrhea, and often secondary to E. coli 0157, and also can be secondary to sugar toxin induced endothelial cell injury, which release large amount of membrane multimers and then get MAHA. Usually these patients, they need a support care. The hematology side, usually we look for the patient as a whole. We look for his blood pressure and his vital sign, blood pressure, and we look also for urine for hematuria and also for blood stool. And usually this case managed by from our side just support care and need to follow up by nephrology. We have a typical hemolytic anemia syndrome, which also there is a micro and basic hemolytic anemia, but renal failure is typical in this atypical HUS, no history of diarrheal disease, and the pathophysiology of this hemolytic anemia syndrome is chronic uncontrolled activation of the complement system due to loss of function mutation in CHF and CHI and MCB and THBD genes, or gain of function mutation in CCD or CFB genes. Lab testing, usually we nephrology will ask for CD3, CD4, CFH serology, and CFI serology. And treatment, they give anti-C5 antibody or ocrelizumab, recombination humanized monoclonal IgG that target C5. Usually this is MCQs questions, but usually we just in MCQs we give it, but usually this case managed by nephrology team. We have MAHA, which is secondary microangiopathic hemolytic anemia, and DIC from infection, and also can happen from maternal autoimmune disease like antiphospholipid syndrome or lupus, or sometimes growth can induce, monogrowth can induce this MAHA. So this is about MAHA. Then we will go for congenital hemolytic anemia. We have RBC's membrane defect like hereditary spherocytosis, hereditary erythrocytosis, and hereditary ovarocytosis. And then we have RBC enzyme deficiency like G6PD and pyruvate kinase. We have hemoglobin defect, which already they talk about sickle cell disease, anemia disease, and thalassemias are unstable hemoglobin variant. If you talk about RBC membrane spherocytosis, this is the most common cause of non-immune hemolytic anemias, especially in North Europe, around 1 in 2,000. But also we have in our Middle East area, and often diagnosed sometimes incidentally. Example are prolonged neonatal jaundice, and intermittent symptoms of hemolysis, especially with the viral infection. And we have splenomegaly with extravascular hemolysis, and also we found high MCHC over 36, and spherocytes on the peripheral blood smear. Nowadays, we know that all the work toward the molecular studies now all talk about it. And usually for this patient, we need actually the initial management by this lab and this clinical finding, but ended by molecular study for this enzyme defect and targeting genes. If you talk about RBC membrane spherocytosis, there is abnormality of ankyrin and spectrin and protein 4.2 or band 3, which we talk about the vertical connection and horizontal correction in RBC membrane. This is one of the abnormality in it, which lead to this to form a complex that holds cytoskeleton to lipid bilayer vertical abnormality. And ankyrin is a common abnormality or most common abnormality in this spherocytosis. This is a common question in our MCQs, and it is inheritance at autosomal dominant, majority like 75%, and autosomal recessive, most clinically severe like 25%. Abnormal in beta spectrin also common, and severe abnormality in alpha spectrin are more. And also there is high binding affinity to ankyrin spectrin, and make like 3-fold more than beta, more 3-fold less than alpha spectrin, and usually it is autosomal recessive. Red blood cells, lipid bilayer and cytoskeleton, are red cell membrane and lipid bilayer, and the membrane has a flexible cytoskeleton membrane mutation vertical. This was to mention earlier. In vertical connection, we have spherocytosis, and in horizontal connection, we have elliptocytosis and varocytosis. Elliptocytosis, there is some cases, it is not uncommon. Then we will go to still continuous RBC membrane. Spherocytosis also can do what called osmotic fragility, red blood cells lysis in different hypotonic sodium chloride connections, and usually patient with spherocytosis has increased fragility. We have what called E5M, usually bind normal red cell within band 3 on lipid bilayer, and normal level of band 3 with ankyrin and protein 4.2 spectrin complex, and also there is a flow cytometry measured about bound on RBCs. But nowadays, usually we'll look just clinical symptoms and lab supporting, and we'll wait for molecular study in advance. But in a simple country like in Sudan and many other areas around us, we'll go with this clinical presentation and lab to support that. Also still with RBCs membrane spherocytosis, abnormality of ankyrin, spectrin, and protein 4.2 or band 3, Southeast Asian, African, and Mediterranean background. Horizontal defect lead to ellipsoid shape, range of clinical severity, most minimum hemolysis, large spleen, more are autosomal dominant, may have poikilocytosis at birth. And then usually this patient, it is autosomal dominant. Sometimes we can just with huge spleen and hemolysis, sign of hemolysis, and with the lab we will see this what's called poikilocytosis initially, and also we can see the CBC of postpartum. You can see this ellipsocytes, and usually it is sometimes it needs just early years, or maybe in the first month, there is some support with RBCs, then spontaneously will resolve and remain as ellipsocytosis, which is usually found in the postpartum when we have a child, newborn, or in early few months of life. Southeast Asia variant due to single band 3 mutation, only heterozygous state, homozygous is lethal. In this Asian variant. So we continue congenital hemolytic anemia RBC membrane, what called still hereditary pyropoikilocytosis. This inheritance of hereditary erythrocytosis abnormality, also a spectrin heterodimer formation abnormality. Most are African American. Range of clinical hemolysis, many are asymptomatic. If you see in this slides how it looks like bizarre RBCs. Then we will go for congenital hemolytic anemia RBC enzyme deficiency, like G6PD pyruvate kinase deficiency. This is the most common, and we will talk about the background of this RBC membrane deficiency, enzyme deficiency. Hemoglobin and the red cell membrane are constant risk for oxidative injury. The red cell does not utilize the oxygen it carries and relies on glycolysis for energy. Hemoglobin remains soluble. If oxidized, can become insoluble and thus lead to hemolysis. Iron in heme is ferrous, reduced status, and reduce in order to maximally carry oxygen. Ferric does not ferric, which is 3, does not carry oxygen and is called methemoglobin. G6D is essential for maintaining a reducing environment in the red cell. Glutathione hexose monophosphate shunt. This is what's called monophosphate shunt, which it is a circle which is from glucose will lead to glycolysis by glutathione, lead to production of glucose from this and energy to the cell. Then we have which now this sorry, I will make it clear. Yeah, this energy from glycolysis, extract energy from glucose, 10 steps. The vertical direction lead to hexose monophosphation, G6DP produce glutathione, and it ends through this cycle end by phosphate pyruvate or production of pyruvate. So when we talk about G6PD deficiency, it is a hexose monophosphate pathway. If you see glucose 6-phosphate by glucose 6-phosphate dehydrogenase converted to 6-phosphogluconate, which lead to ribose 5-phosphate, which lead to ribose 5-phosphate, and energy from NAD to NADP, and glutathione reductase, which from glucose to 2GH, which is producing hydrogen is released, and this is what called hexose monophosphate pathway. Sorry. So when you have RBC enzyme deficiency, pyruvate deficiency, G6B deficiency, we have it is X-linked, most common human enzyme defect. Mediterranean, African, and Southeast, and Asian, and Middle East is the most common area. There are approximately 160 mutations of G6DB. Many patients have only a decreased half-life of the enzyme. Most patients are not hemolyzed unless exposed to oxidative stress, example, favipiravir or some drugs. Patients often have a history of prolonged hyperbilirubinemia in newborn period, yet not hemolyzed. Diagnosis of, we check G6PD activity. However, younger red cells are higher G6PD activity. Need to check when not hemolyzed. So when you talk about this variant of enzyme production, actually sometimes we see during neonatal period is a prolonged neonatal hyperbilirubinemia, and just we check the level of G6PD, and sometimes the child can found with intermittent. When have intermittent hemolysis, they have intermittent jaundice, and sometimes according to this level of enzyme activity, sometimes the child can come to us older, example in 4, 6, 7 years, and just appears suddenly with this finding, and we discover it is a G6DB. This due to variant level of G6DB activity. Also, sometimes you can find some female with this G6DB. It is not uncommon. You can find it in a female, or also this X-linked, as we know the X hybridization hypothesis. So sometimes we see a lot of female in our area here with this G6DB. So not among boy only, not among only small kids, also older kids and female. And usually the management of the G6DB will give, if its hemoglobin is low, less than 770, we will give back RBCs, and we will do serial analysis. Sometimes child, and most of the time child, need to be admitted for observation and to observe hemolysis and to support use back RBCs transfusion. And if this hemoglobin is acceptable, we can just make a follow-up in near soon clinics. Okay, consequences of oxidation. Methemoglobinemia is a denatured hemoglobin and can precipitate, lead to Heinz body formation in RBCs. This can help make the diagnosis of RBC membrane abnormality. As example, in any hemolysis, G6DB peripheral smear, there is a Heinz body, but it is also what called bar body, or Heinz body in blood smear. Okay, still we continue congenital hemolytic anemias. If the intrinsic enzyme defect, the G6DB is called, there is a variant, which is the most common in African American variant. The clinically significant one and most common is A. Only order RBC are affected by the abnormal enzyme activity. Oxidative exposure usually only cause abrupt but mild anemia. Older cells only. Drug precautions, you know that, Salva, antibiotic, interferon, and Dapsone. And and sometimes if the patient come to us with hemolysis and we measure G6DB, we can find it at normal levels, because usually G6DB in all cells, and if there is a hemolysis, the young cell, it is have a normal G6DB levels. So at time of hemolysis, no need to do G6PD levels. We can follow the still we can follow the blood smear, or we support patient with management, and later we can do that. Intrinsic enzyme defects, the Mediterranean variant is the second most common, is more severe in Mediterranean variant. A variant is common in African, and the severe variant is common in Mediterranean. Clinically more severe because affect all age of the RBCs, severe hemolysis. So not like the A variant, which in old cells, this affect all ages of the RBCs, young RBCs and old RBCs, and severe, which might require transfusion, extravascular and intravascular hemolysis can occur. Hemolysis usually occur with provocation, medication, or infection, and is not spontaneous. So it needs some triggers to happen. Okay, pyruvate kinase deficiency takes pyruvate from glycolysis and help to use it for energy by generating ATP. Deficiency in pyruvate kinase 1 in 2,000. Due to deficiency, RBCs have less energy and thus shorten lifespan of the RBCs, and extravascular hemolysis happen. So treatment with splenectomy, and also this patient they need transfusion till we will do splenectomy. And usually, if not initially regular transfusion, and usually when they have hemolysis by infection or by any triggers, we will give that RBCs and ended by splenectomy. Still, we continue RBCs enzyme deficiency, what we call pyrimidine 5 nucleotide participant in degeneration of RNA. Deficiency lead to pyrimidine left in RBCs. These pyrimidine are toxic and lead to hemolytic anemia on staging, and it is characterized by basophilic sibling, and it is autosomal recessive, and lead directly inhibits pyrimidine 5 there's no treatment available. Actually, this is not uncommon, but they like it in the in our MCQs, and it is lead hemolysis, and on staining we characterized by basophilic sibling. This is a characteristic, and it is autosomal recessive, but it is uncommon to see patient with it. Then we have hemoglobin defect, which already they talk about it, the sickle cell anemia and thalassemias and other variant. Thalassemias also they talk about it. Then we'll go for acquired hemolytic anemia, like autoimmune, which is called downward, and what called BCH, which is called paroxysmal cold hemoglobinuria or Dennis-Lanchester hemoglobin anemia. Autoimmune, a hemolytic disease of the newborn, and non-immune extrinsic hemolysis. It causes splenomegaly, by splenomegaly, medication, physical destruction, March hemoglobinuria, and one calendar effect. So we'll talk about extrinsic hemolysis, which caused by autoantibodies mediate. It is IgG, is the most common type. IgM bind transient to an fixed complement, detected by complement activation on surface. No direct measure of IgM. C3 is detected instead of IgM. If you will search for antibody in the lab, IgM usually bind transient and fixed complement, so we can detect it by complement on the surface node. So it is indirect. We detect C3 instead of IgM. IgG and C3 are detected by direct home test or direct antiglobulin test, which is called DAT. So direct home test to detect IgG and C3, and we mentioned that C3 is instead of IgM. Indirect home test or indirect antiglobulin test, IAT, detect antibody in the serum. Peripheral smear is fluorescence, and if adequate motor response, reticulocyte, possibly Rolox. This is in smear, so we do for this extrinsic hemolytic anemia, which is mediated by antibodies. We will do home test, direct home test for IgG and C3, and we do indirect home test to detect the antibody in the serum. And if we did a blood smear, we will choose the spherocytes and also the small red cell reticulocytes, which are premature cells, and sometimes we saw roll-ups, which is many cells attached to each other. Extrinsic hemolysis, which is called warm agglutinin disease, autoantibody IgG mediated. This is that intrinsic, it is IgG, IgM, and there is autoantibody in the serum. Intrinsic, it is warm agglutinin, and it is IgG mediated. Often best agglutination at warm temperature, then called warm autoimmune hemolytic anemia. So this antibody, we need often best agglutinate at warm temperature because of this called warm autoimmune hemolytic anemia. Typically, is extravascular cells are coated with antibodies removed by spleen or liver. Because of this, we found that patient have big spleen. Thus, usually no hemoglobinuria. Treatment: steroid, IVIG, immune suppression, rituximab, anti-CD20 antibodies, and splenectomy. So in this type, we need splenectomy. Extrinsic hemolysis, this IgM-mediated hemolysis. IgM is a much large antibody, combines several red cells, often best agglutination at cold temperature, thus called autoimmune hemolytic anemia. Typically is intravascular cells directly hemolyzed by IgM antibodies, might be hemoglobinuria. Treatment: support care, keep patient warm. Sometimes we do plasma apheresis, but this patient need to keep warm. Okay, what called BCH or paroxysmal cold hemoglobinuria? It is mediated extravascular hemolysis often following a viral illness. Usually, patient will give a history of viral illness, upper respiratory tract infection sometimes, and often occur in children and median age 5 years. 30–40% of autoimmune hemolytic anemia in these children due to BCH and this polyclonal IgG directed at the B antigen. So this is 30 to 40 of autoimmune hemolytic anemia in children, and it is, as we mentioned, it is a polyclonal IgG directed at the B antigen. This is most important for question and also in our MCQs. Often best agglutination at cold temperature, but then fixed complement at warm temperature, and thus hemolyzed at warm temperature. Again, often the agglutination at cold temperature, then fixed complement at warmer, and just hemolyzed at warmer temperature. Refer this cold temperature and fixed complement at warm temperature, and then hemolyzes at warm temperature called Duras-Landsteiner antibodies. Require with unrelated topics. I will not go deep on it. We see non-immune hemolytic anemia, and this which usually happen in the patient with mechanical heart valve, like any patient have a any heart problem and have mechanical heart replacement, you can see this type of hemolytic anemia. And also if there is any left ventricular device, and also in microvascular compression anemias, say marsh hematuria or marathon runner, and also fresh water drawing osmotic stress can cause this type of anemia. I actually have a disclosure for these lectures. It is from ASCO 2015, 2017, and 2021. And sorry, it is not easy topics, but need to look for the clinical symptoms and clinical exam and lab support in our area. And if in advanced areas or there is questions, now is you can go for molecular study as update labs. Thank you for hearing me and for attendance. And also I can support with in email, the lectures in email or WhatsApp. And any questions, ready to answer it and to share with you.
Okay, thanks a lot. So you can send it to my